My talk today is on AI-assisted radiation dose reduction for cardiac CT and AI-assisted improved imaging of stents and calcified plaques. In this talk, what I will discuss is firstly, what is the risk to us or to you from medical X-rays, methods to lower radiation dose during cardiac CT scan acquisition, how technological advances help, including methods of image reconstruction, and I will discuss briefly what our iterative reconstruction is, and what is AI-assisted image reconstruction, which uses deep learning, and what is our experience with this and our results. And finally, I will talk a little bit about using a new AI software called PEAK to improve imaging of calcified plaques and coronary stents. Firstly, what is the risk of medical X-rays to a patient? Simply put, this is a theoretical increased risk of causing cancer. CT scans are estimated to be in the very low risk category, with the risk of cancer estimated at 1 in 1,000 to 1 in 10,000. And this takes many years, more than 20, and so therefore the people or patients most at risk are children. But at the same time, you should note that the statistical risk of death from cancer in any person's lifetime is about 1 in 5, and the risk of any of us developing cancer, such as in men, is about 1 in 2 or 1 in 3, and women 1 in 3 to 1 in 4. The background radiation that we all receive each year from the sun and the soil is about 3 millisieverts. Aircraft crew and people who live at high altitude receive more and have no increase in the risk of cancer. Background radiation of 3 millisieverts is equivalent to about 300 chest X-rays. And current cardiac CTs in our center are about 2 to 3 millisieverts on average, including the calcium score. Can be lower than 1 millisievert depending on the patient's size and heart rate and whether they have irregular heart rates, for example. The main methods to reduce radiation dose during cardiac CT is firstly, lower the KVP. The relationship of KVP to dose is exponential. So by reducing the KV from 120 to 100 KVP, reduces the dose by 30 to 40%. Similarly, if you reduce the dose from 100 to 80, the dose drops quite a lot. You can lower the tube current, but the relationship is linear, and so, but it still helps to reduce the tube current MAS. You can reduce the scan range. That means not overscan. Therefore, you should always try and reduce the scan range in the Z-axis and not have too wide a scan range. And you can use the technology improvements provided by the CT vendors. These are usually, however, only available on high-end scanners. The technology improvements we've seen over the last few years include hardware advances and depends on the vendors or the brand of CT you buy. For example, high-pitch spiral acquisition, special new detectors, multi-energy detectors or volume scanners, where you can do one heartbeat acquisition of cardiac CT data. Software improvements have also occurred. There's dose modulation, metal artifact reduction, iterative reconstruction of data, and artificial intelligence, including deep learning based on deep neural networks. So the methods of CT scan reconstruction used on Canon CT scanners since 2012, which is quite a long time ago, 10 years, iterative reconstruction has been available, and this has been improved. And now, over the last 2 or 3 years, there is now artificial intelligence available to help reconstruct data. So what is iterative reconstruction of data? This is a method of reconstruction of data to create images using complex mathematical algorithms. Needs a large amount of computing power. This is your workstation where you do your work, but this is to reconstruct images, but this is the computer required to do the iterative reconstruction. How does it reduce dose? It reduces radiation dose by allowing low dose exposure scans with lower MAS, and this results in lower images, which are then processed to make nice readable images. So you scan with a low MA or MAS, the acquired data is noisy, the raw data is reconstructed using iterative reconstruction, and also you can use, or actually the iterative reconstruction also reconstructs from the reconstructed data, blends both sets of data, and then you get a final image which has little noise. So for example, this is a scan done almost 10 years ago. 67-year-old lady, 100 kV scan. The MA was 90, and you can see the image quality is quite good, and the dose was 0.3 millisieverts. AICE, or artificial intelligence aided reconstruction, is a deep learning based reconstruction of images using a deep convolutional neural network, and this learns from high quality iterative reconstructed data sets. This is available for all parts of the body, not just cardiac. So how does it work? It uses AI and deep intelligence and deep learning. The deep convolutional neural network is provided with thousands of examples of high quality CT scan exams, and the artificial intelligence algorithm is tasked to reconstruct the data input and trained on this data. The deep learning method is used to differentiate signal from noise so that the algorithm can suppress noise while enhancing signal. And this essentially learns from itself and becomes more accurate and efficient. Once validated, the neural network contains all the knowledge required to perform an advanced quality reconstruction from virtually any variation of patient size and exposure dose. As I said, once the network is trained and validated, and this is done in Japan, then the AI reconstruction is applied to your scanner or to the scanner on site, where it does not continue to learn. So once you scan a patient, the on-site CT data scan is acquired. The algorithm, which is stored on that computer that I showed you earlier, already trained on AI, does not change and reconstructs the data immediately into images with high quality image quality and reduced noise. The software comes, as I said, available for all body parts, including cardiac, and you can select what's called mild, standard, and strong. I won't go into this too much, but basically you can select mild, which has slightly higher noise, standard, and strong, which has slightly lower noise. We've had AICE since end of 2019, and this is some of our results that we looked at 2 years ago when we collected the data at the end of 2019. The data was analyzed for image noise, including signal to noise ratio and contrast to noise ratio, and then we estimated the radiation dose for each method, as well as looked at the image quality. And say, for example, you can see that this is iterative reconstruction, the old method, the newer method first, and then using artificial intelligence, you can see that by using AICE, the increase in signal to noise ratio was 35% and contrast to noise ratio was 40% compared to iterative reconstruction. The radiation dose, as I mentioned, AICE is integrated into the scanner console to reduce the X-ray tube voltage and current automatically. All scans use auto KV and auto MA, and in general the KV will change automatically depending on patient size. In this study we didn't exclude any patients at all, unlike many published papers, so we included patients with high heart rates, for example, or patients with atrial fibrillation. And the majority of our patients were scanned with a wide RR window from systole to diastole. The reason for that is that because the radiation dose is relatively low, we don't always try to get just scan in diastole in case the patient's heart rate changes on the scan table. And you can see our results. The dose reduced using AICE by up to 23%. And of course, if you increase the KV, the dose does increase. But this is usually for larger patients. So here's an example of a patient on the scanner table, and this is the console shot, and the dose was 0.8 millisieverts. You can see the image quality. This is the artificial intelligence gives images of well-defined plaque and sharper vessel wall compared to iterative reconstruction. There's better visualization of the lumen to assess for coronary stenosis. And you can also see improved image quality of stents. The spatial resolution appears to improve. Look at the difference in the image quality of the stent reconstructed with iterative reconstruction and artificial intelligence. Other unexpected benefits of using AICE, if you combined it with SEMA or single energy metal artifact reduction software from Canon, this also uses iterative reconstruction approach on raw data, and you can see much improved reduction metal artifact in this patient, and you can see the right coronary artery much better in this patient. AICE appears to improve image quality when scanning patients with high heart rates. This is a patient with a heart rate of 80, and you can see the image quality appears to improve, and also reduces noise and improves image quality in large obese patients with high heart rates. This is a patient with a heart rate of 90 beats per minute, and you can see the image quality with this image reconstructed using iterative reconstruction and using AICE. As I mentioned, this software can be used for scanning other parts of the body. This is a paper that was published in Radiology in 2020, looking at reduction in dose for pediatric patients. As I mentioned earlier, we really have to be reducing our dose on pediatric patients. And you can see that the software reduced the dose by more than 52% in this small study of 19 pediatric patients. This is an example of one of our patients that we scanned last year. 3-year-old boy with neuroblastoma. You can see the tumor. We scanned the thorax, abdomen, and pelvis, and the estimated dose was 0.5 millisievert, which is pretty good. So in conclusion, AICE deep learning reconstruction software can be routinely used during your daily workload. It's not only for cardiac CT, but also body CT. It is robust, rapid. In spite of the huge computing power needed, you can get the images reconstructed pretty quickly and on site, almost immediately, and it's easily used. In our experience with cardiac scans, it increased signal to noise ratio by 35%, contrast to noise ratio by 40%. And the improved image quality means it's easier to see the vessel lumen for plaque, assess for stenosis, and assess coronary stents. It's also seen to be helpful in obese patients and patients with high heart rates. It also allowed us to reduce radiation dose by up to 25% compared to using iterative reconstruction for image reconstruction. Next, I'm going to talk about current major challenges for cardiac CT imaging include, we all know calcified plaques affect coronary CT results. You can get a false positive, that means overestimate stenosis, as well as this false negative result, which is underestimating the degree of stenosis when there are calcified plaques present. Coronary stents, often we had difficulty to assess accurately for presence of intimal hyperplasia or in-stent restenosis. In-stent restenosis means narrowing of the lumen of more than 50%. This is especially for stents with diameters of less than 2.5 mm. And with coronary stents, you can get a false negative result. That means we can miss in-stent restenosis. The main reason for these difficulties is related to partial volume averaging and beam hardening artifacts, which are also related to the spatial resolution of the scanners we currently use. Just to remind you, spatial resolution is determined by detector width, which is the main factor affecting spatial resolution, as well as spatial resolution determined by the software used or reconstruction algorithm. But the main factor affecting spatial resolution is detector width. Canon has a scanner that has detector widths of 0.25 with 164 rows. And this scanner has improved spatial resolution because of this and is available or uses iterative reconstruction to reconstruct the images. So for example, this is a paper that was published or in press at the moment, and you can see the difference. This is patient with calcified plaque, and with the high resolution CT, you can see the lumen, and this was reported as showing no significant stenosis in the proximal LAD, and you can see the cath result correlating it. Canon has released new software using AI-assisted software called Peak. And so to overcome the challenges of visualization in stents and heavily calcified vessels and plaque, this software produces sharp image quality without compromising on noise and temporal resolution or dose. And it's been trained on data sets from the new scanner, which has 0.25 mm detectors. So for example, this is conventional CT, and you can see the difference using this new software in the image quality of the stent. How it works is very similar to the AICE or software used for radiation dose. There's a deep learning used. This network is trained on high quality cardiac cases acquired on the scanner called Aquilion Precision, which has 0.25 mm detectors, and these are acquired and reconstructed with AICE deep learning, and then the data sets are validated and applied to the scanner on site. So the software is available or applied to the standard 320 scanner, in particular the new model called Prism. Here are some images from Dr. Marcus Chen that was presented at RSNA recently. You can see an image reconstructed with iterative reconstruction, and the difference using the AI reconstructed algorithm. Similarly, here's calcified plaque reconstructed using this artificial intelligence algorithm. So, in summary, the new released AI deep learning software or algorithm called PEAK has been trained on high-resolution data sets of stents and calcified plaques scanned with the ultra-high resolution scanner, which has 0.25 mm detector width. It shows better image quality compared to using iterative reconstruction with no additional radiation dose. This enhanced spatial resolution algorithm, PEAK, is now available for users of 320 MBCT, in particular the latest model called Aquilium Prism. And in future, you will have the choice to use AICE or PEAK reconstruction software when doing cardiac imaging. We don't currently have the software or the scanner, but I'm looking forward to being able to use this in the future. Thank you for your attention.